Hi, this is Dr. Bob Dannenhofer, the Public Health Officer in Douglas County. It's January the 15th, and this is another one of our Facebook Live updates. We've been doing this now since March. So for way too many months now, we've been talking about COVID, but there's still much more to talk about. But this is a time for you to go ahead and ask questions, and we're perfectly happy to go ahead and answer those questions. I get a sense of what those questions are going to be about today, and so we'll go through those. But let me first start by telling you what's happening with COVID in the world, and then we'll get to your questions. So in the world, still a very active pandemic, 93 million cases. We hit 2 million deaths today. The number of cases in the world is high, but not going up anymore, staying at about 750,000 a day. 750,000, that's a lot of 750,000 new cases every day. It's a lot of new cases, and this disease is still very active in the U.S., especially in pockets of the U.S., which we'll get to, the U.K., Spain, Portugal, Sweden, some of the other European countries. And we're also seeing a fair amount of continuing disease in South America, and seeing some in South Africa, which is a bit of a concern. But at the same time, there are parts of the world which are really very, very quiet. So when we looked yesterday between Australia, China, Hong Kong, South Korea, Taiwan, and New Zealand, they had a total of less than 1,000 cases, but a population of 1.6 billion people. Rhode Island had about 1,000 cases yesterday, and they have a population of about 1 million people. So about as many cases in tiny little Rhode Island, which is much smaller than Douglas County, than in all of those other areas in the Pacific. And while we might not believe all the Chinese data, I think all those other countries are very believable. In the U.S., we're 24 million cases and 398,000 deaths. We're likely to cross 400,000 deaths this weekend. The cases have stopped rising, but they've leveled off at an incredibly high rate of 250,000 a day. Hospitalizations have leveled off at about 130,000 a day, but deaths keep rising, and now we're averaging over 3,400 cases a day. We've had several days in this last week where we've been over 4,000 deaths a day. The CDC said today that they would expect 92,000 deaths by the end of the month. That's a lot. So in last year, COVID, probably the third or fourth leading cause of death overall. In December of 2020, it was the leading cause of death, and it's likely to be the leading cause of death in January 2021. Overall life expectancy is down. So life expectancy, which is the chance that a baby born that year will live to a certain age, and it's the 50th percentile, and life expectancy, which had really been going up for years and years and years, has stagnated in the last few years, and this year is definitively down, especially for blacks and Hispanics. Disease is still very active in California, Arizona, Utah, Oklahoma, South Carolina, and Rhode Island. It's sort of a smattering of states around, and those areas are really, really, really struggling. In Oregon, we're at 130,000 cases and 1,737 deaths. You know, we went up before Christmas and then came down, but we're starting to go up again with an increases in cases. Hospitalizations are flat, but deaths are increased as those cases that people got in the end of November, December are there. In Douglas County, we're at a little over 1,600 cases, 43 deaths. We're averaging about 17 cases a day, which seems to me to be incredibly high, but again, it's the second lowest large county in the country, only behind Honolulu. We're seeing several very large outbreaks now, 2 large church outbreaks, and from that, then a number of workplace outbreaks. There was a large teen party around New Year's Eve, where we're starting to see more and more cases really spread about. So these young adults went to a party and then they work in other places, and they've been bringing it to those other places that they work. Well, I'm sure there are going to be questions today about vaccines, so let's just get to the questions. So last time they asked 2 questions that stumped me. One of the questions was, is there a deferral for blood donation after getting the vaccine? There is no deferral, so you can get the vaccine and then give blood. But since they're going to take your temperature when you do it, there are going to be people who aren't going to be able to donate blood for a few days after they get the vaccine because you won't be able to answer the questions correctly, like, are you feeling great today? and you say, no, I'm not really feeling great, then they would ask you to defer. So it may decrease blood donations a little bit. The second question was about somebody who was traveling to Japan. Oh my goodness, I looked it up. It's very complicated. Half of it is in Japanese. They only approve certain tests, so you can't have just any test like a rapid Binax test. You need to have certain tests, and they have to be done right before you leave. So this is going to be complicated, but there is a group in Portland called AFC, Urgent Care in Portland, that works with travelers to go ahead and get them the forms that they need so they can travel to other places. And the number is, for people looking to travel, is 503-305-6262. And AFC Urgent Care can go ahead and do the test and get you the forms that you need. They're expensive, $200 at least. And so it's really, really, really confusing. So this next question is, the county has had months to work out the logistics of vaccinating large people against COVID-19. You knew it was coming. How are you now just working out the details? Okay. So let me go back to the vaccine. January of last year, we recognized there was a new virus out there. By mid-January, we had the genome for the vaccine. That's the genetic code. And in the springtime, we did one of the great things during the pandemic is we did Operation Warp Speed. We worked with large companies, some of whom made vaccines, but some of whom were going to make vaccines. And we worked with a bunch of these companies to make vaccines because we realized that a vaccine could be a way out of this pandemic. So they worked with 6 different companies to make vaccine, and what they did is they ordered about 100 million doses of vaccine from each of the companies. So Moderna, Pfizer, Janssen Pharmaceuticals was with J&J, AstraZeneca, Novavax, and one more, and they did that. And so if it all worked through, they had 600 million doses of vaccine, which would be enough to vaccinate at least 300 million people, which there's 330 million people in the US, so that sounded like a great deal. This summer, as the Pfizer vaccine was being produced, Pfizer asked the federal government if they wanted more, and the federal government did not say yes, and then Pfizer then gave this vaccine to other countries. Well, it turns out that only 2 of the vaccines got approved, so only the Moderna and the Pfizer got approved, and so we were only at, depending on how you look at it, either 2 or 400 million doses of vaccine, but since everybody needs 2 doses, that was not nearly enough. And all those doses of vaccine could not be delivered immediately, so the number of vaccines that were delivered was very low. So to give the vaccine to all the people who need it, the vaccine has to be produced by the companies, gathered by the federal government. Since they bought all the vaccine, you're not allowed to buy this on your own. They bought all the vaccine. That vaccine needs to be distributed to the states, and then from the states to the local people. There are a lot of people who need vaccine, right? So we think everybody should get vaccine, but the high priority populations are people over 65, people with pre-existing conditions, and essential workers. There are, in Douglas County, about 30,000 people over the age of 65. There are, in Douglas County, about 20,000 people who have pre-existing conditions. And there's about another 15,000 people who are in the essential worker group. Now, there's a little bit of overlap, right? So, I'm going to be 65 soon, and I have an underlying condition, and I'm also in healthcare, so I would only get counted once. But there's probably overall about 60,000 people in Douglas County who fit for that. And so the logistics are, how do you give vaccine to 60,000 people? We're ready to give as much vaccine as they can give us, but our total allocation for next week, remember, 60,000 people we need to vaccinate. All of these require 2 doses, so we need 120,000 doses. Our total allocation for vaccines this next week is 1,000 doses. So the feds allocated to the state allocated to us for 1,000 doses. Those 1,000 doses are going to be gone in no time. So that's not the problem. It's not the local logistics that's the problem. It's the fact that there's a very limited supply of vaccines. And Alex Azar, who's the secretary of HHS before, said, 2 things are going to happen. Everybody over 65 can get a vaccine, and we're going to have this big stockpile of federal vaccines that we're going to release. So There was no big stockpile of federal vaccines they were going to release. There was this story that the feds had this big stockpile of vaccines that they were saving for the second dose. Never existed. And so this week's allotment to Oregon, which was supposed to be this big amount, went up by just a little fraction. And then in future weeks, it's actually going to go down. And so that's where the problem is. The problem is the vaccines that are coming from the feds to the state. It is clearly not vaccines when it gets to Douglas County. So in Douglas County, we have 23 different providers signed up, plus Mercy, plus Lower Umpqua Hospital, plus the ambulance services, and soon the pharmacy. So we have plenty of people to distribute vaccine. We just don't have vaccine. So we have people who come in and they try and, they want more vaccine. So we have somebody who delivers it to the different places in the county. And as they deliver to the different places in the county, there's only so much vaccine here. So this is not a failure of local logistics or local planning. This is a failure that there's not enough vaccine. Now you could go back and you could say the Fed should have ordered more, and they might have. Now they did in overall order enough. However, there was no way to predict last March or April or May when they were making these things, which of these vaccines would work and which didn't. Now, the federal government did have an opportunity to buy more Pfizer vaccine last summer, and for some reason they didn't take them up on it. They just recently took them up on getting another 100 million doses, but they won't arrive until the end of this year. So that's what the problem is. There's not enough vaccine to give to all the people who need it or want it. Right, because we think in addition to the 60,000 people in those groups, likely 40 or 50,000 will want it. But then there's other people too, young people and whatever who want it. And then there are kids who at some point when a vaccine is approved will likely want it. So we have a long way to go to getting enough people here. So again, there's no local logistics which are the problem here. All of the troubles are, I believe, from the federal supply. Now you look at the numbers and you say, well, it looks like this, Oregon got delivered all these doses and they've only given a bit. So some of this, you have to understand the details. So again, the feds say we're going to deliver 100,000 doses to Oregon next week. Once they say they're going to deliver it, those doses are counted as delivered. Well, as anybody who works with Amazon, the promise that you're going to get something and it actually showing up at your door are not certainly the same thing. And typically the number they say they sent is a week or so before we get it. So today they told us what the allocation for next week was. We won't arrive till next Wednesday, so those doses obviously can't be given because they have not arrived yet. The second thing that happens is when you give the vaccines, you need to put them into a system called the alert system. And it takes a little while. There's a lot of data to put in there, and it takes a little while to do that. And you have up to 72 hours to put that data in. So there's a little bit of delay in the amount given and a big delay in the amount that you receive. So it looks like you received a lot more than you did, and it looks like you've given less vaccines than you did. So there's a lot of sort of complexity to the system along the way. There is not lots of vaccines sitting around waiting to go to someone. Now, there is some vaccine because we are supposed to have 2 doses of this, and there is some vaccine where they're waiting for the second dose. So as somebody who swabs knows, I got vaccinated earlier in January, and there's going to be presumably a shipment of vaccines for me to get my second dose on February 2nd. It may arrive January 23rd. It's held for the people who are supposed to get it on the 2nd. Because it's being held for that time, it obviously can't be given because it's being held for the person needing to get it on the 2nd. Now that may all change. We may change the way we do second doses or whatever, but right now the feds have said you must hold on to the second dose for what's going on. So it's a big problem, and it's an enormous problem because there are a lot of people who want vaccines and there are much less vaccines out there. I'm sure we'll have more vaccines. So is there significance to having COVID antibodies in the blood if there were no symptoms of the disease? So we do know that many of the people who have a COVID infection will be asymptomatic through the course of the disease. So if you've never had symptoms but yet have antibodies, I would assume that you had an asymptomatic infection sometime in the past. Well, the good news is we think that people with asymptomatic infections and have antibodies have some protection against reinfection. So that's a good thing. Should you get the vaccine? Yes. So the only people who've had the COVID disease that we would say hold off is if you're just getting over it, you might want to leave that vaccine for somebody else who has no protection. but I would do nothing different other than celebrate the fact that you've already had it and you were asymptomatic. So, similar question, Lee says, if a person's uncertain but wants to find out if they had been infected over the past year, can they get an antibody test locally? Yes. And so talk to your doctor and they can do it. They cost about $200, although sometimes it's picked up by insurance. And we would recommend that you go through one of the big labs, Mayo, Mercy, Quest, LabCorp. All of them do a very nice job on these antibody tests. And if you want to know, I'd have you sign up. Okay, so are we supposed to sign up somewhere for vaccination? I'm 75, diabetic, stage 3 kidney failure, Sjogren's, all those kinds of things here. How do I sign up for the vaccine? So the governor had a press conference today that sort of explained what the Oregon approach is going to be, and I think it's a reasonably good approach. So the approach is that between now and January 25th, we're going to work on the Phase 1A population. You are not in the Phase 1A population. The Phase 1A population are hospital workers, people who work in healthcare, first responders, EMS, people in nursing homes, people in memory care facilities. So it's that group. The 1A group, we're signing up now to try to get done as best we can by January 25th. So that's the group we're working on. Starting January the 25th, they're going to work on school personnel, teachers, and others. So it appears between about, and these dates are not exact, between January 25th and February 8th, they're going to try and work on the school population. There's 2,900 or so in Douglas County that fit in that group, and we'll work on that group between January 25th and February 8th. Starting February 8th, we're going to start doing seniors, and rather than having all 30,000 seniors sign up at once, we're going to do them in what are called reverse age bands, kind of like what they did in the UK. So we're going to start with people 85 and above. The next group we're going to go to is a lower age group, and when they get there, those details haven't been worked out yet, depending upon how much vaccine we get from the feds. Now, if the feds were able to give us 1 million doses in Oregon, we could get everybody done in 2 weeks. But that is really unlikely to happen. So we needed to stage it in some way. So we're going to do the people over 85, then the people over 80, then the people over 75 and whatever. So when they get to the 75, they'll do it. Now, I understand you've got another number of other pre-existing conditions. It is incredibly hard to parse that all out. I can tell by looking at you or looking at your license or looking at your birth certificate how old you are, and can get that exactly to say how serious your pre-existing conditions are versus somebody else and what the relative risk is. So a 63-year-old with a bunch of comorbidities, are they at higher risk than a 79-year-old who has no comorbidities? And it's so hard to know, and it's going to be impossible to figure out. So Oregon is going to do it simply by an age distribution until they get to the people who are 65 to 70, and then they're going to start including people with that. So you at 75 would be not in the January 25th group, which is the teachers, not in the February 8th group, which I think is going to be people above that, but I think sometime at the end of February. By the time we get to the groups, we are reaching out to the groups themselves to know. It's really hard to reach out to a group like you because it's probably going to be for you 6 or 8 weeks, and so much could change in 6 or 8 weeks. This week we're reaching out to the people in the 1A group, and I think we have a very good strategy for reaching out to the people in the 1A group. And so we're going to do the 1A group between now and January 25th. If you are in the 1A group, that is, you're working in healthcare, you are a first responder, then you should contact us at vaccines@douglaspublichealthnetwork.org, and we'll get people signed up in that group. We would hope by the time we get to February, we'll have 25 or more local providers. I think with all your issues, you very likely see a primary care provider who may well have a vaccine. And the hope is you'd be able to get that vaccine at your doctor's office. So let's just say that on a certain date in February, we're opening up for people 75 and above, that you have a primary care doctor in town, you call them up, they have vaccine, they put you in for next Tuesday at 3:30, and that would be the ideal way to get it. I don't really want you waiting in 25-hour long lines and fighting with other people for vaccine. The best way to do it would be to get it from your own doctor. So this is a question about Hashimoto's. So Hashimoto's is a very interesting disease. Hashimoto's is probably more common than anybody knows. So Hashimoto's is an autoimmune disease of the thyroid. Actually, it's one of the few thyroid diseases that we see in the kids. And so what happens is your body attacks its own thyroid gland. And during the time of the attack, you can have some swelling in the thyroid gland. Sometimes your thyroid levels can be high or low. But then typically as the Hashimoto's go away, then you have a low thyroid thereafter. So Hashimoto's is common. Of all the autoimmune disease, probably the most common that's out there, clearly the most common in kids. And so it is your body attacking your own thyroid gland. And so we worry about these diseases, which we call autoimmune diseases, and what's going to happen. So there are a bunch of autoimmune diseases: rheumatoid arthritis, lupus, Hashimoto's. And while in general we think they probably are a risk factor for COVID, they're not one of the strongest. Actually, it turns out that hypertension seems to be one of the worst. Diabetes seems to be one of the worst. And these other diseases, not so much. Now the question is, what about vaccine in these diseases? Well, when they did the vaccine trials, they did pick people with all kinds of different diseases, including autoimmune and other diseases. And they didn't see really any difference between people who had autoimmune diseases and others. So I think the story is you should probably get a vaccine when it's out, and I would do it. So Jackie says, is any idea when I can make a vaccine shot appointment? So going back, depends on what group you're in. If you're in the 1A group, and I think we've talked to almost everybody in the 1A group, but if you're in the 1A group, please send us an email at vaccines@douglaspublichealthnetwork.org. If you are in some other group, let's say you're 67 years old, again, Oregon is going to work through in a reversed age band fashion. And at some point, probably in February or March or maybe early April, they'll get to your age group. And then we're going to have places for people to get vaccine. Again, we would really prefer that people get vaccine at their doctor's office. It's a place you should get most of your care. But we'll also have big events, drive-through events, and other kind of things to get people vaccine. We also hope that by that point, that the pharmacies have it too, because we know pharmacies are a big deliverer of vaccines. They do actually more flu vaccines than anybody else in the county, and so we're hoping that the local Walgreens and Safeway and whatever else get signed up to be COVID-19 vaccine providers. We looked at the list today, and I think they are all signed up. So I think in the end, we're going to have 35 different places to get vaccine in the county. That will be great. So do we have any plans for a drive-through vaccination event? So we have plans for big events. We're a little worried about drive-through, and the reason we're worried about drive-through is this vaccine seems to have a few more side effects than the flu vaccine. So when we do flu vaccine, people say my arm hurts, but we don't have very many other reactions. With this one, about 1 in 10,000 people has an anaphylactic reaction, which is a severe and immediate immune allergic reaction, can be serious. Really not good to do that really not good to resuscitate that in your car. And then there are a bunch of other people who will have kind of funny things. And again, I don't want people driving if they're not feeling right. So we're going to do these big events, but we're going to do them more likely indoors because of the side effects. But we do have plans. We have plans for one on the 23rd, but the one on the 23rd is for select high-risk populations in 1A. So it is not... if you're in one of those select high-risk populations, you will get invited. So if you get an invitation, great. If you don't get an invitation, then you're not in one of the groups. So there's a myth saying that old people are dying in droves after getting the vaccine and that it's being covered up. Dale Ann asks, well, the story is that a lot of old people in nursing homes are getting vaccines, because that's our plan, that people in memory care facilities and nursing homes are getting vaccines. And we're very, very, very carefully looking at deaths in nursing homes. There are a lot of deaths in nursing homes. I mean, people who go to nursing homes die. Some die from COVID, some die from unknown places, and some die a week or 2 weeks or 3 weeks or 5 weeks after they get the vaccine. Every one of those deaths in people after they've gotten the vaccine are carefully looked at. We did have one in Douglas County where someone got the vaccine but then died a few days later of something totally different. And I reviewed that with the state medical examiner, And I really don't think that that is the case. That had anything to do with the vaccine. Now, there is one case in Florida of a doctor who had thrombocytopenia after. Thrombocytopenia can occasionally be seen with vaccines, so we're carefully looking at that. But thrombocytopenia can also happen for no good reason. And so we don't know if this doctor in Florida got the thrombocytopenia from the vaccine or they got it from something else. But let me tell you, a couple of the hundreds of thousands of people who have gotten the vaccine, that is likely going to save tens of thousands of deaths. So, in this case, when you look at the risks and the benefits, it does look like the vaccine is a good way to do it. Yeah. So Jessica says, with the bad news about the government misrepresenting stockpile doses. Again, the federal government said that they had these stockpile doses and they give them to us. Any of us who looked at the numbers said, well, that doesn't make sense, because they'd have to be counting the doses twice for there to be this big stockpile. And it turned out last night we found out that there was no stockpile. And that's right. So anyway, we're going to start vaccinating teachers on or about the 25th. We have a great plan in Douglas County to do that. The goal would be to get through. Again, there's 2,900 people that are not going to want the vaccine, but probably somewhere between 1,500 and 2,200 will want the vaccine. We think we can do that in a week or two. We've got a great plan for putting that together. And then right after that, then we would get to the other groups. So the process for vaccinating looked like over the next few weeks. As I said, we're only going to get 1,000 doses for the entire county next week. Those are going to go to our community partners, Viva, South River, Umpqua Health Alliance, a bunch of doctors' offices, and they're going to go to those groups, and then those groups are going to go ahead and use it and vaccinate people. So again, we're still in the 1A group, healthcare workers and first responders. So when does Douglas County expect to start seeing vaccine like other counties, drive-through clinics? So Multnomah County and Marion County do not have the same strategy. So they've not given any vaccine to doctors' offices and clinics. They're doing everything through these huge, and they're not exactly drive-through. If you look on YouTube, they're kind of big halls at the fairgrounds, and they're doing it that way. With the last few weeks, they've only got like 200 doses or 200 doses or so. There's no sense doing a drive-through for 200 doses. And so they were all given out in clinic settings. The one big event we look to have on the 23rd is for select really high-risk people in Group 1A. And then if we get a lot of vaccine, we can have more of these big clinics. Really doesn't make sense to do a big clinic, which takes a tremendous amount of planning. You only get 200 doses, right? Because the 200 doses went to a doctor who took 50 of them and they gave it out. Another doctor took 30 of them, they gave it out, and then another group took 150 and they gave them out. It's part of the regular thing. It gets in your medical record. It gets immediately into the alert system because it's in the electronic record. There's not a lot of waiting around. You're in the doctor's office, so it's a very safe place to get it, and that's the way we would prefer to go ahead and do it. And some counties have gotten a lot more vaccine than we have. So Umatilla has gotten much more vaccine than Douglas County. I think this is just an early step thing. So some counties have gotten a tremendous amount of vaccine, and they have said, oh, we've been able to do everybody. Well, they just happen to get a lot of vaccine. Now, some of the reason is because some of these counties have really been struggling with the amount of disease. So if you look at a place like Umatilla County, they've been struggling since July with a tremendous amount of disease. So they got a lot of disease and a lot of help to do these clinics. Douglas County has gotten a relatively low amount of vaccine, probably because we've had a really low number of cases. But I think over the next few months, he's going to do it. So Bruce said, has Oregon only used half the vaccines that were actually delivered? Okay, so it might look like that. So, but remember, the number of doses that we have is inflated because these are ones that are on the way from the feds. That'll get here, but they'll take a week or so to get here. And then it's also undercounted the number that were given because the vaccines take a little while to get into the system in the state to do it. And there are some vaccines that are waiting for the second dose. So again, as I said before, if you got the first, so I got my first dose on January the 6th. 4 weeks later, on February the 2nd, I think it is, I'm supposed to get my second dose. So on the end of January, they will deliver doses for everybody who got a first dose to get their second dose. Well, if they deliver those on the 23rd of January, and I'm not supposed to get it until the 2nd of February, but it's there for me on the 2nd of February, it'll sit for those 9 days in between waiting for me to get it. So it looks like it's not given, but it's because we were told to hold for the second dose. Now, I totally predict that within the next 2 or 3 weeks, we're going to come up with new federal guidance about the second dose. I predict that that's what's going to happen, is they're going to come up with new guidance that, the second dose maybe isn't as important, and you should do more people with the first dose than fewer people with the second dose. So if you think of it, that you get optimal protection with 2 doses. So for younger people, a little less clear for seniors, but for younger people, get 1 dose, they get about 80% protection. When young people get 2 doses, they get about 94% protection. So if you had dose, would you prefer to give lots of people 1 dose or half as many people 2 doses? Well, in terms of total protection, it makes more sense to give more people 1 dose and wait on the second dose until more vaccine gets there. And in fact, the UK has decided to do just that. They're going through a terrible time with this new variant virus, and they want to get as many people immunized as possible, so they've chosen to do that. The feds, who make the decisions on this, have not yet changed their guidance, but they may well in the next week or two because of the very slow pace of vaccine rollout in this country. So that was Bruce's question. So Clover says, what do you think about the vaccine for a person with low platelets and no known cause? Well, that's always a worry, right? Because you can have low platelets for a couple of reasons, but far and away the most common reason is that your body attacks the platelets and they live a shorter lifespan, and because they live a shorter lifespan, you have a lower number of them. And so when your body is attacking your own platelets, it's like the Hashimoto's, where your body is already attacking itself, and thus anything that you do that interferes with your immune system is a problem. So this is clearly a time to talk to your doctor. So Debbie says, I'm starting to hear more people frequently claim to have gotten COVID while wearing a mask. Do you think this signifies that a new strain is here? We don't know about the new strain. So the new strain is a further mutation. So you remember, we've talked for months now about the 614 mutation that makes the spike protein a little sturdier. So in the past, the spike protein had a little part in it that was like a score on a piece of glass or score on a stick, and it would crack at this one point. Well, with the 614, that score went away, and the spike protein was a little bit sturdier, and it was more contagious. This new one now, the 501 mutation, makes it adhere more tightly to the receptor, the ACE receptors that it adheres to, and so it may be more contagious. The way you know about this is you actually have to do a genomic analysis of the virus. Not something you can do locally, not something you can do easily. It's actually very complicated to do, and you can see. And so they've been looking at genomic analysis on this. We don't think it's here in Oregon yet, but it certainly could be. In terms of people who say, I've been wearing a mask and I got this, boy, when we ask people, there's almost always a very clear break in protection that leads to the virus. Now, I won't say that there's no one who ever wore their mask all the time and got it, but although that's sort of the word out there, that I did everything exactly right, when you asked them, I said, well, I did go to lunch with 5 other people. So presumably when you went to lunch, you took your mask down while you were eating, or we went to church and we don't wear masks at church. Those are the kind of places where it does spread. But the worry with this new virus strain out there is that it does seem to be maybe 50% more contagious. Well, 50% more contagious is crazy because this disease is already really contagious. So 50% more contagious than really contagious is very worrisome. So Stacy says if the feds don't have a stockpile, where are vaccines coming from in the state? So what happens again is the manufacturers make it, they give it to the feds. Now they told us before they were giving us half and stockpiling the other half for the second dose. Well, turns out they really weren't. So the vaccines we're getting from the state now are coming from the feds, which are coming direct from the manufacturers. So the manufacturers would produce for Oregon 100,000 a week. The feds would give it to us, and then our state would distribute it. And so the vaccines now are coming from ongoing production by Moderna and Pfizer. This is a worry because anybody who's ever run a process knows that something could happen, right? There could be a fire in the plant that happens. There could be troubles with the machine that makes it. There could be a power outage or something that happens. And so it's really a bit worrisome. And the Moderna vaccine, which is a great vaccine, is especially worrisome because Moderna itself doesn't make vaccines. So Moderna is this little startup company in Cambridge, and they have somebody makes the glass, somebody makes the labels, somebody makes the diluent, somebody makes the stoppers, somebody makes this, who makes the liquid that it's in, and these all have to come together. And so a disruption in any of those areas, the bottle manufacturer has a flood or something else, could disrupt the process here. And that's why that's why this is a rickety supply chain. So would people with a history of severe allergic reactions to insects hold off on getting the vaccine when they can? So we don't know about that. We do know that about 1 in 10,000 people seems to have a severe allergic reaction to this. None have died, but some have been sick, pretty sick, admitted to the hospital, really uncomfortable with this. And they've mostly been people who've had previous reactions, especially to insects, to sulfa drugs, which are kind of antibiotics, to nuts, or to a previous immunization. So it's a bit of a worry. Certainly if you were going to get it, I'd talk with your doctor. If you are going to get it, I'd give it in a place that's well set up to handle an allergic reaction. And you might want to think about holding off to the newer vaccines. The J&J vaccine is going to be not quite as effective, I think, as the Moderna vaccine, but because it's a live virus vaccine, is much less likely to have an immediate reaction. So perhaps people with allergies would want to wait. But again, not very many people have had severe allergic reactions. Less than 1% of the population has had it. And so if that 1% doesn't get vaccinated immediately, that's okay, as long as the other 99% of the population does. Okay, so Lorena says, I know someone who's been exposed, spent all afternoon trying to get a test. Why is there still a problem? So there are 30 places in town that have these rapid tests. You should be able to get a rapid test in any of those places. Maybe privately you can message about where they tried to go. If somebody's symptomatic. So the deal about exposure. So if you're exposed and you want to get a test, so this is it. I was exposed yesterday, I want to get a test. That test is basically worthless. If you've been exposed, you should get the test on the 6th day after exposure. So, getting the test today, if I was exposed this morning, my test is never going to show my infection from this morning. And in fact, can be misleading because it says, it's negative. So if I was exposed this morning, I should quarantine and then wait until Saturday, Sunday, Monday, Tuesday, Wednesday, next Thursday, I should get a test. So if you could, Lorena, tell us specifically what the story is, we'll look into it. So Casey says, are there strategies in place to reach Black, Latino, Native people with the vaccine? People in that demographic appear to be at higher risk and also more likely to mistrust vaccines. Indeed, this is a problem. So what we have recognized in this pandemic is that people in those groups, as well as people who are frontline workers, bus drivers and others, have seemed to get the disease at a higher rate and to die at a higher rate. And so this really is a group we need to work on to see. In our area, we think many of the people who are at highest risk are these people called home care workers. So They're typically low-income workers who typically have many clients, and they're going all around the county visiting their clients. And it's a disaster when they get sick, because when they get sick, they're now exposing a dozen or so really high-risk people every day. So we are worried about that. So how many different variants are out there? At least 1,000. At least 1,000. So again, when the way viruses work is they reproduce, and as they reproduce, they copy their genetic code. And when they copy their genetic code, they can make little mistakes. Those little mistakes are called mutations. Most of them are nonsense mutations, and they kind of fall away. But some are mutations that will make it stronger. This virus, in general, is not a super quick mutator because it's got a proofreading mechanism on making it work. So what I tell people is, it's, for example, it would be writing down a recipe, and if you wrote down the recipe and were copying it, you might make a mistake. And actually, some of the mistakes might actually make it taste better. So instead of 1 teaspoon of vanilla, you put in 2 teaspoons of vanilla, and you make it and say, well, you know what? That does taste better than the previous. Now, most of them are going to be crazy, because it'll say 0 teaspoons of vanilla one time, and you say, that tasted terrible. I couldn't even taste the vanilla. But there are occasional, maybe 1 out of 100 mutants, which is actually better than the original. And so there are a lot of mutations. Now, most of the mutations are nonsense mutations. Instead of vanilla, they spell it with 3 L's. Well, you still know what it is. It doesn't change very much. But occasional one does change it and makes it more potent. And so the UK and the South African variant there are a bunch of different mutations, but especially in the 501 sequence, there's one in Brazil that they say is also more contagious. And then there's one that they found in Ohio, and we can't be sure if they're all that different, because this is really complex stuff. It seems that for the vaccines are based on a snippet of RNA, and it seems that so far that the vaccines work against all of these new variants. But the concern is that if we continue to allow so much disease to spread, that we are eventually going to come up with a variant which isn't covered by the vaccine. That is going to be really horrible. Now, the way they make these vaccines is they put a snippet of mRNA in there, and they go ahead and make it. So the good news is that if there is a new variant that isn't covered by the previous vaccine, it's relatively easy to go ahead and change that mRNA to do it. But it'll be 3 or 4 months until that happens. And so the goal now is to decrease transmission, because every transmission is an increased episode for a mutation. And the mutations, again, don't happen all that often, and especially bad mutations don't happen all that often. But if there are 93 million cases in the world, and we're adding a million cases, 750,000 cases a day, the chance that some of those mutations that people make are actually going to make it a more potent virus goes up and up and up. And again, my biggest concern was the mink farms in Europe and in Oregon, where these mink farms gather together many mink. And mink don't get very sick with this virus, so they all died off, and they would die off, and the virus would die with them. But they can live with this virus, and in fact, they found some wild mink outside these farms. Presumably they escaped or jumped over the fence or whatever they did, and then they've now spread this, and that's where this disease can spread very quickly. And if you had 100,000 mink together and they all got infected, which apparently they did, the chance for a mutation to spread in a population, that is enormous. So I think we're being very cautious about these. And again, there's nothing we can do to prevent a specific mutation, but what we can do is prevent the overall number of mutations. All right, so while she's gathering some more questions here, a few other things that have come up. One of these is about the new recommendations for quarantine. So previously, if you were exposed to a case, the recommendation was that you would quarantine for 14 days. It's a long time, especially for people who are needing to get back to work or anything else. So the CDC looked at this and they said, well, most of the people get symptomatic in the first 10 days and not in the 11th through 14th day. So you can, if you're otherwise reasonably healthy, cut your quarantine down to 10 days. And then what they said is that people had negative tests on the 5th, 6th, or 7th day, very rarely had symptoms after the 7th day. So now you have three choices here. 14 days, the safest but the longest. 10 days, a bit shorter, but a little less safe. You may miss the occasional case that becomes symptomatic on the 11th or 12th day, or the 7 days with testing. The advantage of that is you only miss a week of work, but you might miss 5 or 6% of the people who have that. This next question is, are there any vaccines approved for children? There's none for kids less than 16. Now, they're working on it. But again, because kids have had a relatively better time with this than seniors, they did not put kids in the trial. Now, there is a trial out there to expand it for kids. They're having a hell of a time signing up kids. So, new vaccine comes out there and say, we need volunteers to try this vaccine. You know, I've lived a big, long life, and things have been great. And so I signed up for the vaccine, realizing it could be a risk to me, but, you know, if that risk would be outweighed by having this vaccine approved, I'd be able to do it. However, when it gets to your 8-year-old kid, they say, hey, would you like to sign up your 8-year-old kid for this vaccine trial? And you say, well, what do we know about it? Well, we don't know anything. That's why we're doing a trial. So people might say, well, no, not my 8-year-old or not my 2-year-old. And that's why it's really, 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 really hard to do these studies in kids, especially when the kids are perfectly well now. And, you know, there could be side effects or other problems for the vaccine. So there's a trial now to sign up kids for a vaccine, but they've really, really struggled to get enough kids to sign up for the vaccine trial. And again, not surprising, because the kids themselves can't sign up, the parents would need to sign them up for it. And I can clearly see why parents are not rushing out the door to go ahead and sign their kids up for a trial. Let's see what else we had here. So one of the things that we were looking at was the 1918 flu pandemic. So the 1918 flu pandemic was truly a remarkable thing. It was truly influenza. It wasn't COVID. It was truly influenza. It started in the spring of the year in probably Kansas and spread to U.S. troops. And then in 1918, during the war, spread rapidly around the world as soldiers moved across the country. It was called the Spanish flu, but it very clearly didn't start in Spain. It turned out that Spain was the only neutral country in World War I, and so they publicized disease in their community, so it sounded like they had a lot of disease. It turned out they had no more disease than anybody else, but everybody else was at war, and during the time of war, they did not want to publicize that they had a flu outbreak. But it was pretty much worldwide. Actually, the death toll was far higher than the death toll from this. It also, rather than affecting, as this one does, mostly old people, this one affected mostly young people. So there had been a flu before that, about 30, 40 years before, that many of the older people had and had some antibodies. So they tended not to get as sick, but the people who got really sick were the soldiers. And there are stories of this spreading through a camp, and within a week got sick and died. So we think of this 1918 flu pandemic, and we think, how does this one compare? Well, that 1918 was, I think, much more severe for young people. And because it was influenza, it tended to do what influenza does, get worse in the winter and the better in the summer. This one has not seemed to follow that pattern. This is a totally different kind of virus called coronavirus. So it was interesting. I'd seen a big deal about the 1918, and there's a lot to look at there. So Gabrielle says, what counts as an exposure? If you're master distance, does that count as an exposure? So in general, we say an encounter, a close contact, is being within 6 feet for 15 minutes, generally. Now, if you were 6.1 feet away for 4 hours, as you might be in a classroom, or you were within 1 foot even for a minute, doing mouth-to-mouth resuscitation or kissing someone, those may be contacts too. So in general, it's 6 feet for 15 minutes, but there's a lot of discretion along the way. And the discretion along the way is really nuanced. I mean, we know, for example, that when you have a big church outbreak and there's 50 or 60 people at the church, it is unlikely that all those people were within 6 feet of each other for 15 minutes. They were likely seated in the pew or whatever else and around a group. But they may have been there for a long time. There may have been singing. So there's a nuance to whether there's a close contact or not. Masking, the CDC says, does not change that. Does not change whether it was a close contact or not, although it clearly reduces your risk. So if somebody said I was exactly 6 feet away for exactly 15 minutes, you'd say, well, that's an exposure. If you're both wearing masks, the risk is much lower. If you were closer or longer, the risk would be higher. And so there is a nuance to this. So people say, for example, I was on a 13-hour flight with, the person seated next to me, but we both had masks. Probably an exposure. However, there's great ventilation on planes, so maybe less. So there's not a bright point where you say, well, more than this, you're definitely going to get it, and less than this, you're definitely not going to get it. Overall, your risk of getting it, if you're a close contact, is about 20%. Only 20%, which means that 80% of the time, even though you are a close contact, you won't get it. And we've seen that. We've seen when people we decide are contacts, certainly not all the contacts get it. Now, what's weird is that there's some outbreaks where there's 5 contacts and nobody gets it. And then there's another one where there's 5 contacts and they all get it. So this disease also is very different in terms of transmissibility. And that's why that makes it so very hard for public health. But in general, being masked does not change our sense of whether you're a contact or not. Now, we find about 3 contacts per case. There are other places that do contact tracing differently. So South Korea and Israel use lots of high-tech stuff to see how many contacts you have. And when they do that, they find a lot more contacts. So they have this phone app thing, which they've tried to bring out in the US, but hasn't gotten anywhere, where your phone knows who you are and where you're at, and by using Bluetooth, I think, it knows who I've been next to. And so that if I get the disease, I put it in the phone that I have the disease, and it finds everybody I was within 6 feet for 15 minutes with, and it sends them a text saying you were exposed. This has not gone anywhere in the US because people are a little creeped out by having the idea that somebody knows where you're at and whatever else. But in Israel and South Korea, they've used things like that to figure it out, and they find that people are probably at 8 or 10 contacts. So I know they're different societies, but I'll bet you in our country we have 8 or 10 contacts too. But people usually only admit to 3 or so. And so this is tough. People are not admitting to all their contacts. It's hard for people to remember their contacts. If they say, Bob, where are you on Wednesday? I'm like, I don't know, I think it was at work. But who did you come in contact with? I don't really remember. It's because I don't write down everybody I have a contact with, and so it would be hard to know. But again, masking is a good thing because it clearly decreases your risk, but it doesn't change the fact that you're a contact. Believe it or not, there are some things that I think that are going to come out of this pandemic, which I think are good. One of those is, I think the mRNA technology for vaccines is likely to be great, because I think the mRNA technology, because it's so much easier to do than growing the proteins, we may be able to get vaccines for some of the things which have really plagued us: staph, MRSA, herpes, maybe even HIV, maybe malaria, because I think this mRNA technology would allow us to perhaps make vaccines for each of those areas. And although COVID has been terrible, if what we came out of this was a new vaccine technology using mRNA, that could really make a big difference. All right, well, it's getting to be 5 o'clock. It looks like we're done with questions here. Again, I would encourage people to listen to the governor's press conference today. I think she explained in pretty good detail about where we're going to go. I can tell you, every bit of vaccine we get, we give right away. I know there's a provider who gave some today, and she wrote this lovely note. So this is the first time they got a vaccine. They got 3 or 4 doses of vaccine, 3 or 4 vials of vaccine. They covered the people in their office. They covered the dentists who live in their community. They covered others. Everybody was overjoyed to get the vaccine and get started. And they gave it all in one day. There's another provider that's going to do it tomorrow on a Saturday, giving it to a bunch of other medical providers around. So we've had incredibly great support from the people around. We just don't have enough vaccine yet. But once we get the vaccine, we're going to get it out. We're going to get it out quickly. And we're going to hope to get it out equitably. You know, what I really don't want to see is people fighting with each other or people cutting in line. Really, 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 we will get to everyone, and we're trying to do it in an equitable way. I think the reverse age band is a good way to do it. So imagine if you say we're going to do people over 85. That's easy to know because I know who's over 85. It's people who were born on or before 1935. And so as a practice, you could call all of them and say, oh, Mrs. Smith, you know, you just had your 87th birthday. We have vaccine for you. Come in next Tuesday and we'll get it done. That's the kind of stuff we're going to see. And then when we're done with that, then we'll go with everybody who's born between 35 and 45. And then next year we'll go to the next group and get everybody done. And this is what we're hoping is that we get people done, that we don't have too much fighting along the way, and that'll work. Now I know there's so much emotion here, and I've been a little emotional this week when there's some decisions that have gone not the way I wish they would. But in general, we've had a lot of great support from the people in the community. In fact, when I get done now, we have a meeting tonight to talk about how we're going to schedule people for our next weekend event. So remember, this next weekend event, everybody else could take this week off, yet they're doing it. I know Monday's a holiday, but I'm sure we'll be working all day to get all these things straightened out. And tonight, you know, it's 5 o'clock at night on a Friday, and yet there's a planning meeting at 5:30 to figure out what we're doing. So people really are working hard. They really care. They totally hear the 62-year-old who's got underlying conditions who wants the vaccine now. I totally hear that. But I think we have to give it to your 90-year-old mother before we give it to the 62-year-old because of the way, way, way higher risk for a 90-year-old. So we'll do this, and we really will work it through. We're not hiding vaccine. We're not making up stories. We really, truly are trying to go ahead and get everybody the vaccine just as soon as possible. So what I'm asking is be safe and be kind. We'll do this again on Tuesday. Thanks.